This is the year that I started working in the NHS as a finance trainee. I was taken in on a training scheme. I was qualified as an accountant within a couple of years, and I've held various positions in finance across Wales. I've only ever worked for NHS Wales, and I've only ever worked for NHS Finance. And I remember the days when money was plentiful and life was good, and there wasn't too much stresses in the world. In 2008, I was appointed to the Finance Director of Powys Health Board. That's the bit in the middle. That's not much there, but a lot of land. At this point, things become really tough. Times became hard, money was tight, what are we going to do about it? And as a quite new and naive finance director, I've tried everything. I tried see if this resonates with you actually, I've tried the everybody save 2%. Whether you've got a budget of 50,000 or 500,000, I want 2% of everything. And as you know, that doesn't really work. It's not particularly effective. I've tried the let's take money off people who are underspending it and give it to people who are overspending. Have you heard that one? And as you know, you try that for a couple of years and some really weird behaviour starts to emerge. So I've also tried benchmarking. Who's doing it the cheapest? Can we replicate that? When you work in a really rural organisation, it's really hard to compare yourselves to other organisations. And do we know that those cheaper alternatives are really effective anyway? In my last couple of years, we were talking about the concept of shift left. I really believe that if we invest properly in primary and community services, it will reap benefits into secondary care. But where's the real evidence about this, and how do we capture how effective that is? So I've tried loads of things, and I was inspired by a neighbouring health board finance director who'd been to Harvard Business School, had learned about value-based healthcare, and came back quite evangelistic about it. And so I did something a bit unusual. I left Powys for a secondment to go and work in my neighbouring organisation for this finance director to learn more about value-based healthcare. So here's the experts. This is what they say. If you Google value-based healthcare, you'll probably come up with a chap called Michael Porter, who is a professor at Harvard Business School, and he describes value as that relationship with outcomes that matter to patient. How do you know that you are treating patients and getting the outcomes that matter to them? But you also need to be able to do that at the lowest possible cost. So if you can improve outcomes, reduce the cost of delivering those outcomes, that's where you get value. That's his concept of value-based healthcare. If you look further into what Michael Porter says, he'll talk about the various pillars of value-based healthcare and the mechanisms for it. And there's a lot of people that will say, well, that's all right for the States, the United States, where they've got an insurance-based system, but how will it work here in the UK? But I really do think he's onto something here. If you can drive better outcomes for patients for the lowest possible cost, that really does drive value. And then in the UK, you might have heard of Sir Muir Gray, and he talks about triple value. He talks about allocated value. How do we move money around the system to get the greatest outcome for our populations? Where is the best way that we can resource our money for population health? We've got technical value, which is similar to what Michael Porter's talking about. When you look at a service, how do you deliver the best outcomes for patients for the lowest possible cost? And then he talks about personalised value. What does it mean to the patient? What is it that's driving their decision-making on what they place as value in terms of good and bad outcomes? And in Wales, we've got a policy direction for prudent healthcare. Kerry Lewis, who's coming this afternoon, will talk to you more about that. So I'm not going to dwell on it too much. But if you look at this, and I'm sure he'll explain to you in much detail later, all good stuff talks about eliminating unnecessary variation, only doing what's needed, do no harm, care for those with the greatest need first, and public and professionals having a co-productive conversation. And then you'll get people saying, well, you've got Michael Porter's value, and you've got Muir Gray's value, and then you've got prudent healthcare. What does all this mean? How does this all align? Well, I think the truth is we're all trying to do the same thing. Michael Porter says there's a clear relationship between outcomes that matter to patient and cost. Muir Gray talks about 3 angles of looking at value, and prudent healthcare, I think, is a really sound operating framework for which we can have a value-based conversation with staff and with the public. So why is this important anyway? Well, if you look at our stats across the UK and where we are in terms of healthcare, we are pretty good. We look good on quality, we look not too bad on accessibility, we're very good on efficiency, and we're certainly really good on cost. But in terms of healthy lives, we're only 1 behind America. That's not good. So it's a health service, but not very healthy population. And when we look at healthcare system performance rankings from the Commonwealth Fund analysis, similar story, really. We're still ranked number 1, but when we measure healthcare outcomes, we're nearly the worst. So we're really efficient. We're doing a great job in terms of efficiency. We're doing not bad in terms of equity. Access isn't too bad, but actually we've got a population that are not very well, are not very healthy, and we can't really say that we're getting great outcomes for them. That's not good value then, is it, in terms of how we direct our money? And the sad news is that money isn't going to get any better. We're still in times of austerity, and the gap between demand and supply in terms of money is only going to get worse. And in Wales, and there'll be similar across other UK governments, I'm sure, we attract 50% of Welsh Government's money. So there's no point going back and saying, can you give us a bigger slice of the cake, please? Because local government's already crying, and the fire service are all crying about the money that health is attracting. So don't bother going back to Welsh Government. They haven't got any money either. So we're in a bit of a mess, aren't we? And we've got public expectations going up. Clinicians want to do better for patients. In Wales, we've got pockets of the fastest rise in ageing population in the UK. And even if we had all the money in the world, we can't necessarily get all the staff that we need. So what are we going to do about it? Kerry Phillips this afternoon is going to talk about, from a Wales perspective, the parliamentary review that was undertaken. And Welsh Government has responded to this parliamentary review by publishing its Healthier Wales, a long-term plan for health and social care. And what's the good news for us working in Wales is they're not talking about reorganisation. They think that our integrated nation of our health boards is the right way to organise ourselves. We're just not harnessing it to get the best outcomes for patients. So they talk about the quadruple aim, which is about we need to improve the population health and well-being. We need better quality and more accessible health services. Interestingly, they've mentioned specifically we need to drive higher value for health and social care and a motivated and sustainable health and social care workforce. So I'm just going to share with you a bit about, so what have we done in terms of value-based healthcare in Wales, just to give you a flavour. And as I said, I'm not an expert, but this is the bits that I've got involved in. So as I said, I went to work in an Iron Bevan. So I was in Powys, that big bit in the middle. I went to work in an Iron Bevan for the finance director there to learn more about what they were doing for value-based healthcare. And they'd already started a relationship with the International Consortium for Health Outcome Measurement, ICHOM, and they had started to collect outcomes for patients in various services. Because of their enthusiasm, and they're a bit of evangelistic, for anybody in Iron Bevan, I'm bigging you up now, they're quite enthusiastic about value-based healthcare, actually influenced the rest of Wales to say we need to start collecting outcomes. And so we have a national programme now for collecting outcomes for lung cancer and heart failure. But remember, Michael Porter's equation says you need outcomes that matter to patients. You need to collect them to drive your service. But what about the cost? So I work in finance. Do we really understand our costs? We can tell you what your budget is. We can tell you average cost of services. But do we use it in a way that drives a change in clinical behaviour? Do we really understand what the difference is between different services and different systems? So I'm going to give you 3 examples of things that I've been involved in, thinking about a costing end of value-based healthcare, using sort of Muir Gray's definitions of personalised, technical and allocative value. And the first one is really quite personal. This is Clive. Clive is my father-in-law. He's rugby mad, as you would. He's a good, proud Welshman. He's played rugby, he's refereed rugby. He's been that man who stands on the line with the magic sponge and runs on the pitch and makes people all better when they've been in pain. But he ended up, it's taken his toll, and he's ended up with a painful knee. And he's referred to the Royal Gwent Hospital in an Iron Bevan, where he had a knee operation under local anaesthetic. He had various physiotherapy afterwards. And the consultant said, "Good news, Clive, the operation was a success. It all went really well." Clive didn't feel great, actually, after the operation. When I said to him, how is it going? He said, "Well, my knee still hurts. I still walk with a limp, and I'm not really any better off. I don't know why I bothered, really." Well, that operation would have cost us about £5,000, and he's asking why he bothered to go through it. And when they've done other exercises across this in other orthopaedic treatments in an Iron Bevan, they surveyed patients saying, "Is it any better after we've intervened?" They've said, a staggering number said, "No, don't feel any better off." What are we doing? We're spending money, lots of money, on services that the patients don't feel valued by. So that's quite a personalised value example. Cataracts, fairly standard procedure. If you've got anyone who's been through it, it's pretty. You get referred, sometimes by an optician, seen by a consultant, operated on, job done. But we wanted to see what was happening across Wales, and this is a whole of Wales exercise where we asked every organisation to map their cataract pathway and cost it. And there's a staggering variation in the number of steps in the process. We've got ranging from 4 to 7, and the staggering range of costs. And I'm sorry to say Powys is at the bottom of the leaderboard there, but so we can start questioning. So why is that different then? Why are some clinicians choosing a different model of care for something that is pretty standard, really, and generating quite significant different costs to those services? What can we do about this? So the next question isn't really, shall we all go for the cheapest, which happens to be in Betsy Cadwallader? The question is, which one drives the best outcome for patients? We don't know. So we're hoping that this exercise will drive a conversation about how do we measure now the outcomes we're seeing through these various models, and let's go for the one that gives us the optimum outcomes for the best value. And the final one is something that I worked on whilst I was on my secondment in Nyron-Bevan, looking at COPD. And all the evidence that's out there tells you, and to the bottom there is the colourful triangle, is the London Respiratory Team saying that the best thing you can do with somebody for COPD is to make sure they get regular checkups with their GP, they stop smoking, they have their flu immunisation, and actually pulmonary rehabilitation, if you've got a certain level of breathlessness, is superb, because what that does is make you manage your condition better, it stops you needing over-reliance on drugs, and then onwards admissions to hospital. When we mapped out what was actually happening in Nyron-Bevan, actually the triangles didn't look too triangular, does it? You know, look at the top one. There's a lot of services that people are not getting access to. And as a consequence, high spends on drugs, high spend on admissions. So Nyron-Bevan did a really interesting thing. They decided that they would reinvest any savings that they generated on drugs. So it's a bit like swapping from one expensive drug to a cheaper drug, but for the same outcome. And they've made an agreement they would reinvest it in pulmonary rehabilitation, because all the evidence says this is the best service for patients to stop them escalating in terms of drug usage and inpatient services. And as a finance director, I find it kind of shocking. I shouldn't. It's pretty obvious, really, isn't it? We should be driving our money to where it has the best possible outcome. And this is why I think thinking about services from a value-based approach will hopefully drive us to better decision-making for our patients. But you need outcomes and cost together. And finally, just to say that there's some really interesting stuff going on in Wales around value-based procurement. There's a lady called Adele Carhill who is leading this work. And this is about having a completely different conversation with the private sector about if we buy your product, we need to know that it works for our patients. And we will start to commission from you on the basis of the outcomes that is generated for patients, not just because it happens to be the cheapest product. A complete transformation of the way in which we commission services. It's new territory, nobody's doing it, but they're already having some successes in terms of renal services, and that's something, a programme that we're trying to learn from and roll out across Wales. But this isn't all going to happen overnight, and I could be really sounding like we've really got it nailed in Wales and we've really got it sorted, and we haven't. This is a long journey. So part of my new role now as the Director of the Finance Academy is how do we tell people about value-based healthcare? How do we train them in it? And how do we make it everyday practice for everyone? And Sally Lewis, who I understand isn't going to be here today, but has been working with Swansea University about grabbing those medical students right at the start of their career and having a curriculum on value-based healthcare so that they get to understand it, learn it, and live it right from day one. In the Finance Academy, we're working to put clinicians and finance together to do some joint work on value-based healthcare. Try it out in your service and live it. But more importantly than anything else, we're trying to encourage early adopters and really flag up this great practice that they're doing. So I'll just leave you with this. I understand you're really good at measuring outcomes here in speech and language therapy, and that's fantastic. Do you use them to drive an improvement in your services? And do you know how much those services cost? And can you explain any variation in them? Because I really think unless you know the outcomes and the way in which you deliver those outcomes and the costs that are used to deliver them, only then will you really know your worth. Thank you for listening.